Alright, now let's talk about some cardiac output variables. We'll start off here with stroke volume. Now stroke volume is the volume ejected from the left ventricle in a single cardiac cycle. And it is affected by what you put into the ventricle, which is the preload, how hard the ventricle squeezes, which is contractility, as well as what the ventricle has to push against, which is afterload. Now, as preload and contractility increases, stroke volume increases. And as the afterload decreases, stroke volume increases. Or to say this another way, stroke volume is directly proportional to preload and contractility, and it's indirectly proportional to the afterload. Now, we'll discuss each of these individually later on, so let's cover what we need to know for stroke volume. Now, contractility increases with anxiety as well as exercise, and it's due to an increase in the sympathetic tone. Now, pregnancy is a much different situation, and it leads to an increase in the total plasma volume. This in turn increases the preload, which then in turn increases the volume within the heart and allows more blood to be ejected with each cardiac cycle. This increased volume also stretches the sarcomeres so that more myosin binding sites will be exposed for the next power stroke, and all of this leads to a further increase in the stroke volume. Now, you're probably going to be asked a lot about contractility, because it has both physiology as well as pharmacology tie-ins. So let's go a little bit deeper into that. Now, to understand the factors that determine contractility, we need to understand how the myocyte works on a cellular level. Let's use this image to help us understand myocyte physiology, and we can talk about how catecholamines and calcium change contractility. Here you can see the sarcolemma membrane as well as a transverse or T-tubule. The long type or L type calcium channels on T-tubules are incredibly important in calcium-induced calcium release that is rather unique to myocytes. These voltage-gated L-type calcium channels are stimulated to open by sodium channel depolarizations. When they open, calcium will flow into the cell. This new intracellular calcium will bind to the ranitidine receptor, as you can see here. This will cause a conformational change in the ranitidine receptor, opening a route for calcium to come pouring out of the sarcoplasmic reticulum. This calcium goes on to bind troponin C, and you get the necessary conformational change in tropomyosin to expose the myosin binding sites for actin, so you get a necessary contraction. Now this is a key point. The amount of calcium in a cell that binds to troponin C will lead to more actin-myosin interactions and is directly proportional to the contractile force. So to say that another way, more calcium means more actin-myosin interactions, which equals a greater or stronger contraction. So what exactly is this PLB and the ATP that's sitting on the sarcoplasmic membrane? Well, the ATP symbol here is representing the sarcoendoplasmic reticulum calcium ATPase pump. And we'll refer to this as SERCA from here on out. So what does SERCA do? Well, it uses ATP to pump calcium from the cytosol back into the sarcoplasmic reticulum for storage until we get another contraction. Now the PLB here stands for phospholambin. Now a phospholambin normally acts to inhibit SERCA, meaning to prevent calcium from being stored in the sarcoplasmic reticulum. But when you phosphorylate phospholambin, it actually turns off this inhibitory process, meaning that SERCA is allowed to increase calcium storage within the sarcoplasmic reticulum. Now this is crucial to understanding how the sympathetic stimulation can increase contractility in myocytes. Because as you might have gathered by now, sympathetic stimulation leads to phosphorylation of phospholambin, and this results in an increase in calcium storage within the sarcoplasmic reticulum. And now that we've established this, you can understand how beta-adrenergic stimulation, or blockade, and drugs such as digitalis, which manipulate calcium concentrations, can all lead to changes in contractility. So with that all said, how exactly does the sympathetic nervous system increase contractility? So as you can see at the top of the image, the catecholamine of your choice, either epi or norepi, will bind to the beta-adrenergic receptor here. Now this beta-adrenergic receptor is located on the sarcolemma membrane, and it leads to increased activity in the G-stimulatory protein associated with intracellular parts of the beta-adrenergic receptor. Now this G-stimulatory protein will ramp up adenylate cyclase activity to produce more cyclic AMP. So what does the cyclic AMP do? Well, it binds to the regulatory domain of protein kinase A, and this action sets free protein kinase A to now phosphorylate phospholambin. And what does cyclic AMP do? Well, it binds to the regulatory domain of protein kinase A, and now protein kinase A is set free to phosphorylate phospholambin. Now once phospholambin is phosphorylated, its chronic inhibition of SERCA is turned off, and therefore more calcium is able to be stored in the sarcoplasmic reticulum for future contractions. Now, protein kinase A also phosphorylates the L-type calcium channels, as you see here. And this process will actually open the L-type calcium channels to allow more calcium to enter the cell. Now this calcium will then bind to troponin C on our myofilaments to expose the actin binding sites on our myosin, which will result in a more forceful contraction. Now I know all that was very intense, but the second messenger system for the sympathetic nervous system is incredibly high yield, so make sure you get this before you move on. So with all that, how does digitalis increase contractility? Now digitalis actually competes with potassium for the extracellular binding site on the sodium-potassium pump seen here. Now this will lead to an overall decrease in the amount of sodium removed from the cell. Or to say it another way, the sodium concentration within the cell will remain high. Now, with the increased intracellular sodium, this will eliminate the sodium gradient by which another pump on the membrane works, and that's the sodium-calcium antiporter, as you can see here. Now, with the loss of this gradient, less sodium is allowed to move into the cell. Therefore, less calcium will be allowed to move out of the cell. This will lead to an overall increase in intracellular calcium. So where's all this trapped calcium going to go? Well, our friend SERCA has no problem pumping it into and storing it within the sarcoplasmic reticulum for future contractions. This will lead to an overall increase in available calcium, and as we showed earlier, will increase contractility. So now let's talk about a few ways to decrease contractility. Now, heart failure with systolic dysfunction means that the ability of the heart to contract has been compromised. Now this is usually due to loss of myocytes after a myocardial infarction, or it can be due to overstretching of the sarcomere and the myofilaments seen in volume overload states. Now remember, with overstretching, you're not going to be able to properly create the crosslinks required for contraction. Therefore, your contractility suffers. Now, acidosis will also cause a decrease in contractility, and this is because protons actually compete with calcium at the L-type calcium channels, as you see here. So with that in mind, how would acidosis decrease contractility? There you go, less calcium is getting into the cell, and less calcium equals less contraction. Hypoxia as well as hypercapnia will decrease cellular respiration and the production of ATP. And remember that hydrolysis of ATP is necessary to reload the myosin head in preparation for another contraction. Also, your non-dihydropyridine calcium channel blockers, like verapamil and diltiazem, directly compete with calcium at the L-type calcium channel. And this again leads to decreased intracellular calcium as well as a decreased contraction. So if you can increase contractility with beta-adrenergic stimulation, would it make sense that beta blockade would decrease it? Yes, of course it would. Beta blockers antagonize the beta-adrenergic receptor, as you see here. Blockage of this receptor leads to decreased activation of your G stimulatory protein. And this results in decreased cyclic AMP. With less cyclic AMP around, protein kinase A is not phosphorylated, and therefore it is kept in its off position. With less cyclic AMP, protein kinase A is not activated, and therefore it is not allowed to phosphorylate phospholambin or the L-type calcium channels found on the sarcolemma. Since phospholambin is not phosphorylated, it will keep its tonic inhibition over SERCA, leading to decreased calcium storage within the sarcoplasmic reticulum. Now, as you can see, this entire process results in a significant decrease in intracellular calcium. And with less intracellular calcium, there is less contraction. Also, another important point to note is that the muscarinic receptor, as you can see here, uses the exact same messenger system, except instead of a G stimulatory protein, it utilizes a G inhibitory protein. And this protein will act to limit or inhibit adenylate cyclase's production of cyclic AMP. Alright, now I know that was a lot, but we'll see this diagram again later on. So let's shift gears to preload. Now, preload is equivalent to the ventricular end diastolic volume, or the volume of blood in the chamber right before systolic ejection. So what exactly determines how much blood is present in the ventricle at the end of diastole? Well, the circulating blood volume, as well as the tone of the veins transporting the blood back to the heart, play a major role. Now, venous return is actually driven by the pressure difference between the veins and the right atrium, and this is defined by the equation venous return equals venous pressure minus right atrial pressure. So here you can see, if right atrial pressure is high, the venous return will be low. And can you think of something that might increase right atrial pressure? There you go. Right heart failure is a great example. Now this will lead to a decrease in venous return to the heart, and the blood will begin backing up on the venous side, and it results in the classic lower extremity edema, as well as hepatomegaly seen in right heart failure. So what if you were to give someone low-dose nitroglycerin? What would happen? Well, remember, nitroglycerin is a venodilator at low doses, and at high doses, it can dilate both veins and arteries. So giving someone low-dose nitro will decrease venous tone, and this will decrease the driving pressure for venous return to the heart. And with this drop in driving pressure, this will result in an overall decrease in venous return. Alright, now let's take a look at afterload. Now, afterload is approximated by the mean arterial pressure, and the mean arterial pressure equals 2/3 the diastolic pressure plus 1/3 the systolic pressure. So in a patient with hypertension, the heart is always pumping against an elevated mean arterial pressure or an elevated afterload. And this increased mean arterial pressure increases the pressure that the left ventricle must generate to eject blood out of the heart. Now, this increased pressure within the heart will result in an increased wall tension, and wall tension can also be increased by increasing the preload, but we'll discuss that more in just a minute. And what does the heart do to compensate for this increase in wall tension? There you go, it thickens the myocardium. Now remember, this thickened myocardium comes from the chronically elevated pressure as well as wall tension within the heart. Now something important to remember here is that when the wall thickens in response to a chronically elevated pressure as well as a chronically elevated wall tension, it's going to do this by concentric hypertrophy. And here you can see an example of a ventricle that is hypertrophy in response to increased wall tension. Now, this is beneficial temporarily because according to Laplace's law, you need an increase in wall thickness to help distribute the increased wall tension because of the increased afterload. Now, this is all done by adding sarcomeres in parallel. And how do you think you could address this to prevent or even slow the rate at which this happens. There you go, you just treat the blood pressure. So in this case, what do you think you would give? Well, the problem here is a high afterload. So you'd want to give medications that end up decreasing the afterload. And this is predominantly done by decreasing the arterial tone, by giving medications such as hydralazine, or giving drugs that inhibit angiotensin II's vasoconstrictive effects, like ACE inhibitors or ARBs. Now, ACE inhibitors and ARBs are particularly useful here because they also prevent venoconstriction, and this helps to decrease the venous tone as well as the venous return and therefore the preload, which will further decrease myocardial work. Alright, so next up we have myocardial oxygen demand. Alright, so when you think about myocardial oxygen demand, equate it to the generation of ATP. You need more ATP to reposition the myosin heads after contraction, so if the rate of contraction goes up, increased heart rate, or the number of contracting myosin actin units goes up, increased ventricular mass, then you have increased ATP and therefore increased O2 demands. This is also why myocardial oxygen demand increases in situations where you have increased contractility or force. In this scenario, you have increased cross-linking of myosin, which is therefore going to use more ATP and therefore more oxygen. You also have increased oxygen demand with increased afterload because the heart has to squeeze harder to get blood out of the left ventricle. And then again, you're going to have increased O2 demand with an increased heart rate. And finally here, you have increased O2 demand when the diameter of your left ventricular chamber increases, because this leads to an increase in wall tension. Now, to help us understand this better, let's look at Laplace's law, which defines wall tension as follows. And it states that wall tension equals the pressure times the radius. Now this is an important concept here because it also shows up in the pulmonary section when you discuss how surfactant helps prevent alveolar collapse. And here it's going to help us understand oxygen demand. So as I just stated, wall tension is determined by the pressure and the radius. As the pressure goes up, the wall tension goes up. And as the radius goes up, the wall tension goes up. So to say this another way, wall tension is directly proportional to pressure as well as radius. So what exactly is this pressure? Well, this is the pressure required to fill the heart and is determined by the amount of blood within the heart, or preload, as well as compliance of the heart. Now how about the radius? Well, now the radius is also controlled by the volume of blood in the heart as well as how thick the wall of the heart is. To help us look at this better, let's take a look at this image. Now considering our formula that we had earlier, which is wall tension equals pressure times radius, where wall tension equals pressure times radius, if we were to increase the preload within the ventricle, this would lead to an increase in wall tension. But if you were to thicken the ventricle, this would decrease the size of your chamber and therefore decrease the radius, which would then lead to a decrease in the wall tension. Now, if you stick all that together, you end up coming up with the wall stress equation, which you can see here. And it reads as follows: wall stress equals pressure times radius divided by 2 times the wall thickness. So now let's work through this in a clinical example like hypertension. So if someone is suffering from hypertension, their heart is going to have to pump much harder due to the increased afterload. And what's the heart going to do here in response? Well, it's just like going to the gym and lifting a lot of weights. The heart's going to get bigger, and the stressed myocardium will add sarcomeres, and it's going to do this in parallel. Now this will be adding bulk to the myocardium, as well as increasing the thickness of the ventricular walls toward the middle. And this will lead to what is called concentric hypertrophy. and you can see an example of this here. The concentric hypertrophy here will also decrease the radius of the ventricular chambers, so this means less blood will be in the chambers, and this will result in a decrease in wall tension because less blood means less pressure. So if we look back at our equation, where wall stress equals pressure times radius divided by 2 times the wall thickness, by adding thickness to the myocardium, we have increased the denominator as well as decreased the radius of the chamber because of the thickened wall. The end result here is a drop in the wall stress. Now this is a good thing in the short term, as the decreased wall stress prevents ventricular overwork as well as failure, but in the long term it turns pathologic. And because patients with hypertension can live with it for a very long time before they develop any symptoms, we're often dealing with the pathologic side effects of long-term chronically elevated high blood pressure. So as we just stated, the ventricle is going to thicken in response to the increased afterload, and this is going to result in our concentric hypertrophy, which will overall lead to an increase in the myocardial mass as well as the diameter of the ventricle. And in time, this is going to lead to further O2 consumption. Alright, now let's move on to the last section, ejection fraction. Now, the ejection fraction is super high yield because whenever you get an echocardiogram, you're going to always look at the ejection fraction to evaluate the ventricular contractile function in a single cardiac cycle. Now, a normal ejection fraction is equal to or greater than 55%. And the amount the ventricle ejects is called the stroke volume, and this can be calculated as follows. Where the stroke volume equals the end diastolic volume minus the end systolic volume. And if we take this difference and divide it by how much we started with, which would be the end diastolic volume, we get a ratio, and this ratio is our ejection fraction. Now, because the ejection fraction is a ratio and not an absolute number, it can be normal in diastolic heart failure, which is due to impaired filling of the heart. Here, if the end diastolic volume decreases, this will cause a decrease in the stroke volume because there is less blood available to be squeezed out of the heart. But in this situation, our ratios are preserved, and therefore our ejection fraction is preserved. Hence the name heart failure with preserved ejection fraction, or diastolic heart failure. Now, if the ejection fraction is decreased, this is called heart failure with the reduced ejection fraction, or systolic heart failure. Now, on the wards, the terms systolic and diastolic heart failure are falling out of favor, and the terms being used now are heart failure with reduced ejection fraction, or HFrEF, which is synonymous with systolic heart failure, and heart failure with preserved ejection fraction, or HFpEF, which is synonymous with diastolic heart failure. Now, let's plug in a few real-life numbers to help us understand this better. So let's say normally we have an end diastolic volume of 120 mL and an end systolic volume of 50 mL. So if we do the math there, our stroke volume equals 70 mL. And if we divide that by our end diastolic volume, we get an ejection fraction of 58%, which is normal because it's greater than or equal to 55%. Now, in systolic dysfunction, the problem here is poor contractility. So all the volumes within the ventricular chamber are going to increase. And this is because the heart cannot pump an adequate blood volume out of the heart per each cardiac cycle. So let's say in this scenario, our end diastolic volume has increased to something like 200. And our end systolic volume also increases. It goes up to 150 here. So now if we plug this into our formula, where the ejection fraction equals 200 minus 150 divided by 200, we end up getting an ejection fraction of 25%. And this is well below normal. So how is this different in diastolic dysfunction? Well, remember, in diastolic dysfunction, contractility is preserved, but the problem is in diastole because the ventricle is poorly compliant and doesn't allow the same volume of blood into the heart. This means that all volumes are going to be decreased, but decreased together proportionally. So let's say in diastolic dysfunction, you have an end diastolic volume that's 100, and you have an end systolic volume that equals 40. And if we plug this into our equation, we see that the ejection fraction equals the end diastolic volume, which is 100, minus the end systolic volume, which is 40, divided by the end diastolic volume, which is again 100, and our ejection fraction comes out to be 60% here. And this falls well within the normal range. Now this can appear super misleading because it appears that everything is normal, but it's due to the proportional decrease in all the volume. So don't let this trick you. And remember, the underlying pathology here is inadequate blood delivery to the systemic circulation due to the decreased cardiac volumes. Alright, well that's going to wrap up cardiac output variables. See you in the next video.